My name is Leslie, and I'm a nationally registered and state certified advanced EMT and an EMS instructor with the state of Utah. Today, we are going to talk about patient assessment for emergency medical responders. We're going to focus on the medical assessment and then have a separate video for the trauma assessment. There are 5 main parts to a patient assessment that all EMS providers use in order to get a full picture of what's going on with each patient. We have to go through a scene size up, primary survey, a history taking, secondary assessment, and a reassessment in order to get the full picture and come up with the most appropriate transport and treatment decision for our patients to have the best outcomes. As an EMR, your main goal is to be able to manage the patient and treat any life threats until emergency medical services can arrive or you can get that patient to some other form of definitive care. The first section of the patient assessment is the scene size up. This covers several different points, and we'll go through each of them individually. So the first one is that you take or verbalize PPE precautions. The second is that you determine that the scene or situation is safe. The third is that you determine the mechanism of injury or nature of illness. In this case, we'll be talking about nature of illness. You have to determine the number of patients, request additional EMS assistance if it's necessary, and then consider stabilization of the spine. This is a critical part of the patient assessment process that happens before you even talk to the patient. In fact, this even happens before you see your patient if you are being called to the scene of some kind of accident or medical emergency. And this is because we need to make sure that we are safe and that we cover all of our bases before we jump into the intensive patient assessment. The first part of the scene size up that we talked about on that last list is PPE precautions. PPE stands for personal protective equipment. We also use the acronym BSI, which means body substance isolation. Those two are referring to the exact same thing. This is just all of the different things that are available to you in order to protect yourself from being contaminated by a patient. This can include gloves, which we would use for every patient no matter what, masks, which during COVID definitely changed things. We use masks way more than we used to. Goggles or face shields, and then gowns. But there's so many other different types of personal protective equipment that we might use depending on the situation. There's more specialized ones. There are like full body suits for hazmat situations. So it's definitely not limited to just these 4 things. The next part of the scene size up is scene safety. In the pre-hospital environment, we cannot guarantee that every scene is going to be safe. It can change really rapidly, and it can become really dangerous without warning. This means that we need to be constantly on the lookout for threats and making sure that we are aware of our environment and that we do something if something changes and it becomes unsafe. When we're determining scene safety, our safety is priority, then our partner, then bystanders, then our patient. We're focused on making sure that those who are not sick or injured stay not sick or injured, and that we only have the one patient that we were called to deal with. So it's really important that we make sure everyone else is safe before we deal with that patient. If the scene isn't safe or it becomes unsafe at any time, we want to stay out of the environment until it has either been controlled by us, if that's something that we can do safely, or law enforcement, security, whatever it may be in the situation that you're in. Next, we need to determine the mechanism of injury or nature of illness. Mechanism of injury, or MOI, is the way in which a traumatic injury occurs. So this is primarily for a trauma assessment. This is going to help us guess what kind of damage would have been done to the body based on what happened. So this could be a car crash, a fall, this could be some kind of sporting incident, and based on what we know about what happened to the patient, we can come up with some kind of guess of what kind of injuries they may have sustained. Nature of illness is primarily for medical assessments, and this is just going to be the general type of illness that a patient is experiencing. This could be chest pain of cardiac origin, this could be an allergic reaction, this could be a seizure, this could be a breathing problem. Those are probably the most common. To determine the MOI or NOI, we usually need to rely on what information we got from dispatch if you're on an ambulance and you're being dispatched out to some kind of call, or from the individual who came and grabbed you because something's going on with someone at work. And so based on the information that were provided by those people, we can get an idea in our head of what we might be dealing with and be able to be prepared for what we're going to see. This can also help us kind of predict what the severity of injury or illness is going to be and the priority of the patient. In a normal situation, we will only have one patient, but occasionally you will have some kind of mass casualty, some explosion, or chemical or gas leak that would cause there to be multiple patients. So it's important that we determine how many patients we have so that we know how many providers or units we need to bring to the scene in order to manage them. You'll learn way more about triage and things like that when you go through your incident command chapters, but it's important to understand that this part of the medical assessment is so that we can bring in additional resources if they're needed and we can begin that triage process. Next, we need to determine whether or not we need additional help. So part of that is going to be based on the fact that we know how many patients we have. The other part of that is going to be what kind of a situation we have. So we may need a paramedic level provider for really bad situations. We may need air medical support if the transport's going to be too long for the type of patient that we have. We might need a fire department or hazmat, water rescue, search and rescue. All of those types of specialized resources may be something that we need, and we need to be considering that early so that we can get them called to the scene because they will take a time to be dispatched and to arrive. To be able to determine what kind of additional help you might need, you can ask yourself a few questions. One, how many patients are there? If there's more than one, you're going to need additional resources, another ambulance, another provider. Two, what kind of condition is my patient in? That's going to determine whether we need those higher level providers or air medical transport and medevac. And then does the scene pose a threat to me, my team, my patient, or others in some way? This could be law enforcement if this is a dangerous scene because of a violent person. This could be hazardous materials team if we have some kind of leak, water rescue if this would be dangerous for one of us that is untrained to go into the water and rescue someone. So those questions can kind of help you understand what kind of additional resources you might need. Next, we need to consider spinal precautions, and this might sound a little bit funny for a medical assessment. However, there are times when a patient who is having a medical emergency gets into a situation that kind of morphs into a trauma assessment as well. So for example, they have a seizure and they fell, or they had some kind of diabetic emergency and they passed out while they were driving and crashed their vehicle. So there are other situations that might have you needing to do spinal precautions, even though you're doing technically a medical assessment. This has changed over the last several years. We used to spine board everyone, but that's not the case anymore. We are moving from spinal immobilization to spinal motion restriction, which just means that we need to be aware of what's going on with the patient, see whether or not they need some kind of support for their spine, whether they've been in some kind of accident that may have damaged the spine, and then protect it, but not necessarily put them on a hard backboard that could potentially cause more damage than is already there. So we need to consider whether or not they fell from a really critical height, whether there was some kind of hyperextension of the, especially the neck, but the back too, or if they hit their head really hard, if there was a gunshot wound. All of those types of things may indicate the need for some kind of spinal motion restriction. If at any point during your assessment you find that you might need spinal precautions, then err on the side of caution and do it, even if that was 10 minutes into your assessment that you realized that there may have been a need. But at the very beginning of the assessment, we'll look, see if we see anything from the beginning so that we can try to catch that early, but then if we need to do that later as well, we can. General impression is actually not listed on your EMR National Registry skills sheet for patient assessment, but it's still really important to understand and to implement. The general impression is just what you see when you come up on the scene, what your patient looks like, what their demeanor is, all of those things that can give you valuable information as to what's going on. So this could be the way that they're positioned. Maybe they're laying on their back, or maybe they're laying on their stomach. Maybe they're bent over, having an obvious hard time breathing. That leads us into obvious work of breathing. Maybe it's really clear that they're having a hard time and that they're struggling to get in a good breath. This could be other obvious life threats, a wound on their leg that's open and spurting blood, or some other kind of open wound or broken limb. This could just be their general demeanor. They're aggressive. Maybe their level of consciousness is low. They look like they're not doing so hot. This could be their skin color. Any of those things that you see, obviously, as you're approaching the scene that could give you information as to what's going on. The next part of your primary survey is the level of consciousness or the level of responsiveness. Now you have a few different options of how you determine this. Um, Most common ones are the AVPU scale, which we'll talk about, the Glasgow Coma Scale, or ANO. Now, AVPU is what the National Registry requires of you to know, and so that's what we'll talk about the most, but just know that the Glasgow Coma Scale, GCS, is another one, and then the ANO questions, or alert and oriented questions, are another way. AVPU stands for awake or alert, V is for verbal, P is for pain or pressure, and U is for unresponsive. The way that we would use this scale is when you go up to them and you say, hey, my name is Leslie, I'm an EMR, how can I help you? If they're able to respond and they're opening their eyes, they're looking at you, they're going to be an A on the AVPU scale. They're going to be awake or alert. Now, if you say those words and they're able to like flutter their eyes or they move or turn, but they're not able to communicate with you, it's obvious that they're not awake or alert, then they'd be a V on that AVPU scale. Now moving down, if they didn't respond at all when you tried to talk to them, then we're going to try pain and pressure. So first I would say, hey, are you okay? Try to shake them. If there's nothing, we would try painful stimuli, and that would be like a sternum rub or a trap pinch. The way you would do that is take your fist and rub your knuckles hard and fast along the sternum. The trap pinch would just be pinching the trapezius muscle of the shoulder and trying to elicit some kind of response. Now, usually they won't just wake up, but they could flutter their eyes, grimace, turn, something like that, and that would mean that they're a P on the AVPU scale. Now, if all of those things don't work and they're still just out cold, they're going to be a U on the AVPU scale for unresponsive. Now, that same question that you asked in the last section for level of consciousness, how can I help you, or why did you call us here today, that gives us the chief complaint as well. This will tell us what their main problem is. That's what chief complaint means. Why am I here? What's going on? This could be that they're having chest pain, or they're having difficulty breathing, or something along those lines. If the patient is conscious, it's really important that you ask this question. If you don't and you just start going through the assessment without asking them, you might miss something really important, the most important thing that is bothering them. Now, it's also important that you don't get tunnel vision here and that you don't just take their chief complaint and assume that that's the only thing going on, because there's a lot of other things that could go on that you still need to ask all the rest of the questions, so that you don't get yourself on the wrong track just from what they said originally. This is also the point where you would look for any life threats. So if they're awake, you can ask if anything else hurts. You can kind of do a full body scan, look from head to toe, make sure there's no major bleeding, and that you don't see anything else that might kill them before you can get through to the end of your assessment. If they are unconscious, then this is the point where you'd also make sure you do a thorough head to toe assessment. Just make sure you're looking everywhere from head to toe to make sure that there is no major bleeding and that they're breathing appropriately, so that you don't miss anything that would kill them before you can even get to the hospital. If you do find any life threats during this section, it's really important that you treat them so that you can make it through to the rest of it. So if you find a life threat, treat it immediately and then return to the point of your assessment that you were at prior to that. After we get the patient's chief complaint and we assess any life threats, we're going to move on to our ABCs. Now, ABC stands for airway, breathing, and circulation. We'll start with airway and breathing, and then circulation will be next. So as part of the airway and breathing assessment, we have 3 parts. We're going to assess the airway and breathing, we're going to assure adequate ventilation, and we're going to initiate appropriate oxygen therapy. Now, the assessment portion, this is where we open the airway using either the jaw thrust maneuver or the head tilt chin lift. We're going to open the airway, look at it, make sure that there are no obstructions. We will also auscultate their lung sounds or listen with a stethoscope to their chest to make sure that we hear clear sounds. Next, we're going to assure adequate ventilation, and this just means we're looking for equal and bilateral chest rise and fall. So that means both sides are rising and falling appropriately at the same time and equally. We're also going to look for adequate depth, rate, and rhythm of those breaths that they're taking. Now, if any of these things are not correct, if they're breathing too shallow or too fast or too slow, we're going to want to do something to intervene, and those will be things that you learn as you go through the course. The next is to initiate appropriate oxygen therapy. Now, this will kind of depend on what their situation is, and we can use a little SpO2 monitor or a pulse oximeter to put on their finger to find out what their SpO2 level is, what their oxygen level is, and using that we can determine what kind of oxygen therapy we need to provide to them. And you'll learn how to do that and how to make that choice later. But we have a few options. We have the non-rebreather mask. It's just a mask that goes over their entire face. It has a reservoir bag beneath it that fills with oxygen, and then they just breathe it in with each inhalation. Next is a nasal cannula, and that's going to be the one that just goes into their nose. And then we also have a bag valve mask device that you'll learn how to use, and that's providing artificial ventilations for them if they're not able to breathe adequately on their own. Now, after we do airway and breathing, we're going to assess circulation. So this has 3 parts on your actual assessment sheet, but we're going to add a 4th part that's still really important, even though it's not explicitly listed. So the first is to assess for and control any major bleeding. So this is looking for anything you might have missed when you went through that life threat scan earlier, but we're looking head to toe, making sure there's no bleeding that we missed. If there is some bleeding, we're going to control it at this point. Next, we're going to assess the skin for its color, temperature, and condition. So what we're looking for is that it's normal color, so their color looks like the rest of their body should look, that it's not pale or gray or blue, which we call cyanotic. Those would indicate that there's maybe some kind of hypoperfusion going on. Temperature, we're looking for warm skin, not cold, not hot. And then condition is going to be dry, not sweaty or clammy or any of those types of things. So normal, warm, and dry is what we're looking for. Then we're going to assess the pulse. Now we're not counting the pulse rate here. We're just getting a general rate and quality. So we're going to feel their radial pulse on their wrist. It's on the thumb side of the wrist. We'll feel for it, and we're just going to make sure that it's generally an appropriate rate. It's not too slow. It's not rapid or bounding, and that the quality is just a normal pulse like you would feel on yourself. Abnormal would be that it's thready or really weak or bounding like we said before. Next, we're going to treat for shock. This is the one that's not explicitly listed, but still really important. That includes oxygen therapy, which we already talked about, positioning the patient properly, depending on their circumstance, and you'll learn what those are as you go through the course. Controlling their temperature, so making sure they're not too hot or too cold, maybe provide them a blanket or cool them down depending on the situation, and then making sure we transport. The way you can remember those treatments for shock, I like to teach OPT for shock, OPTT. O is for oxygen, P is for positioning, T is for temperature, the second T is for transport. So OPT for shock. Now the last part of our shock treatment is actually the last part of our primary survey, which is the transport decision and patient priority. Now you have 2 choices for patient transport decision. You can stay and play, or you can load and go. Now the difference between these 2 is whether or not this patient has some kind of critical problem that's going to require definitive care sooner than later. Those problems would be problems with the airway, breathing or circulation, some kind of bleed, shock, or a spinal problem. I teach A, B, C, BSS to remember these. That stands for airway, breathing, circulation, bleeding, shock, and spine. And if there's a problem with any of those aspects of them, they're probably going to need to go to the hospital sooner than later, so you should definitely load and go. But if it isn't one of those things and there's no life threats right now, you can stay and kind of finish your assessment or do a lot more of your assessment on scene, try to figure out what else is going on, get a good picture before you do that transport. Once you reach a good stopping point in your assessment, if you do determine that they need to be transported anyways, then you would load them up and go to the hospital. But maybe they're the less critical patients, the ones that don't need definitive care as quickly, or maybe don't need definitive care at all. After you complete the scene size up and the primary survey, you move on to history taking. Now, history taking is one of the most important parts of the patient assessment because this is where we get all of the information that we need in order to make a differential diagnosis. This may give us the difference between thinking there was a heart attack versus a rib being out of place, which are 2 totally different things with 2 totally different priorities. There are 2 different sets of questions that we ask for the history taking section, the OPQRST questions and the sample questions. Doesn't matter which one you do first. I just recommend to do all of the OPQRST questions together, all the sample questions together so that you don't miss any. We'll start by talking about OPQRST. O stands for onset. So this is, did the pain or discomfort come on quickly, or did it develop over time? Has it been developing slowly and getting worse over the last 5 days, or did it start 5 minutes ago and it's already at its maximum? P is for provocation. Does anything make this feel better? Does anything make this feel worse? Q is for quality. Can you describe what the discomfort or the pain feels like? This may be chest pain that's crushing or stabbing or tingly. All of those things are going to send us in a different direction for the diagnosis. R is for radiation. Does the pain radiate anywhere else? Do you have any other pain? Do you have any other symptoms or signs? S is for severity. On a scale of 0 to 10, can you rate your pain, rate your discomfort? You may need to change this question a little bit if you're having a breathing problem or something that doesn't have pain associated. But you could say like 0 being totally easy breathing, nothing's wrong. 10 being I can't breathe at all, no air is passing through. T is for time, and this is just how long ago this started. What time did it start at? Next are the sample questions. So S stands for signs or symptoms. You've probably already asked this because you asked for their teeth complaint, but this is another place where you can ask if there's any other signs or symptoms, any other things that are bothering them. A is for allergies. We're going to ask if they have any allergies to anything, medications, other substances, environmental allergies, all of those things are relevant. M is for medications. So we want to know if the patient is prescribed any medications, if they're taking them as prescribed. Maybe they're prescribed some kind of cardiac drug, but they're not actually taking it, or they only take it sometimes. Those are all important. Are they taking any over-the-counter drugs, recreational drugs, herbal drugs, supplements, things like that? We want to know anything that they're intaking or that they should be intaking. P is for past pertinent history. So this is any recent hospitalizations, any surgeries, if they've experienced this exact type of emergency before or anything similar to it, if they have any major illnesses or injuries or diseases that we should know about. This is really easy for people to get totally off and talk about their broken leg from when they were 5. So it's important that you keep them kind of centered on the problem that you have at hand, but it's definitely important to know those major things. L is for last oral intake. So this is when did they last eat and drink, and what did they eat and drink. That can tell us a lot about what's going on. And then what they were doing when these symptoms started. E stands for events. So that's what they were doing when this started. If they started having chest pain when they were mowing the lawn versus when they were sitting down on the couch is going to tell us a lot about what's going on. Now that we're done with history taking, we move on to the secondary assessment. Now in the secondary assessment, we're going to look at all the different body systems and how the present injury or illness may be affecting them and which ones it may be affecting. And this can help us come up with other diagnostic tools or assessments that we might want to do to get a better idea of what's going on for this patient. So for example, if the patient had chest pain, then we're definitely going to look at the cardiovascular system. We might do an EKG, a 4-lead. If a paramedic or advanced EMT comes, they may do a 12-lead EKG, kind of see what's going on, if they can see a heart attack or something like that, some other dysrhythmia. The pulmonary system would definitely be involved because the cardiac and the pulmonary systems are always coexisting, and they affect each other really heavily. So that might mean that we're listening to lung sounds again, or we're doing some other kind of diagnostic test that affects the lungs. The neurological system might be involved. They may have an altered level of consciousness. We might want to look at their Glasgow Coma Scale, or something to that effect. So you'd go through each of these, come up with whether or not you think they're affected, and then use some of your diagnostic tests that you'll learn about in order to assess those. Then we'll move on to the vital signs and other diagnostic tests. So the last secondary assessment is going to tell us kind of maybe what diagnostic tests we're going to need in addition to these vital signs. Now the vital signs that we're going to do should always consist of at least a blood pressure, which you're going to take with your blood pressure cuff and your stethoscope, a pulse, and that's the actual pulse rate. So we're going to feel their pulse in their wrist and count for a whole minute to see how many beats per minute they have. Their respiratory rate, so how many times per minute they're breathing, and the quality. So this is whether or not they're getting full, deep breaths, or maybe they're too shallow. Maybe you hear some abnormal lung sounds. So it's all going to go into the quality. We're going to want a blood glucose level because blood glucose can affect a whole slew of things and can cause all sorts of different types of symptoms. And then an SpO2 reading, which is going to tell us that oxygen level. That's going to be something that we hopefully have already done in order to figure out what kind of oxygen and how much we need to give them. Now that we're done with all of the things that we've talked about, so the scene size up, your primary survey, history taking, secondary assessment, and your vital signs and diagnostics, then you move on to your field impression and interventions. Now we talked about general impression before, and that was what we did in the primary survey where we're looking at our scene, we're looking at our patient, and we're just forming a general idea of what's going on, whether or not they're in distress, if they look sick or not. Your field impression is based on all of the evidence that you've accumulated over this entire assessment, and it's essentially your field diagnosis. Now, it's not a real diagnosis because we're not doctors. We don't have all the scans and the tests that we can do in the hospital, but it is your field diagnosis, and that it's what you think is going on, what you're pretty sure is going on based on everything that you did. Now, once you determine what that field impression is, then you can form a treatment plan for the interventions that you think are necessary. And that might include medication, applying bandages and splints, transporting the patient to the hospital, oxygen therapy, anything like that. And you'll learn about all those different types of interventions as you go through the course. After we're done figuring out what's going on and we do our interventions, then it's really important that we reassess everything that we just did. So the reassessment is going to consist of 5 parts. And this is basically going through your whole assessment again, but really quickly, just to make sure you didn't miss anything and to see what the reaction to your interventions is. So we're going to reevaluate our transport decision. Has our original decision changed? Do we still need to go really fast? Are we maybe not needing to transport at all? Repeating our primary survey, going over our ABCs again, making sure our life threats are still controlled and that there's no new ones. Repeating our vital signs. So we're going to do that every 5 minutes if the patient's in pretty critical condition, every 15 minutes if they're stable. So this is going to be our blood pressure, heart rate, respiratory rate, and then usually blood glucose, SpO2. And then we're going to evaluate the response that the patient had to the treatments or the interventions that we provided. So has the severity changed? Has their breathing improved? Depending on what we're doing. And then we're going to repeat the secondary assessment, go over any of those diagnostics again that we maybe did at the beginning that we might need to recheck and just make sure that those systems are still on their way up instead of getting worse. Now, after you've done your entire assessment, your reassessment, and you're handing off your patient to someone else, you need to be able to give an accurate verbal report. So this might be once EMS arrives and you're giving them to the EMT or the paramedic who's going to be taking them to the hospital, or if you are the one transporting, this may be your handoff to the nurse at the hospital in the emergency room. To ensure that continuity of care, we need to make sure that this is accurate and thorough. So there's a few things that your report needs to include. So we have this kind of template that you will need to follow. That this is, we have, we found, we did, they responded, and then your ETA if you're transporting. So this is just you identifying yourself. I'm Leslie, I'm an advanced EMT, or this is ambulance 38, whatever. We have a 38-year-old male complaining of chest pain. So it's usually age, gender, and chief complaint. Then we found, so we did a 4-lead EKG and we took his vitals. These were his vitals. This is what we found in that 4-lead. Or we did a stroke scale assessment and this is what the results were. This is the interventions that we performed. So we gave him an epinephrine injection or we provided oxygen, any of those things that you did throughout your assessment. Then how they responded. So they are feeling a lot better now. They went from a 10 out of 10 pain to a 5 out of 10 pain, or however else their interventions affected them. And then the ETA, if you're transporting, how long it's going to be until you arrive. So 5 minutes out or 10 minutes out, etc. If you can get down this whole assessment really effectively and you can do it quickly but also thoroughly, it can be really important to your patient's outcomes. And this will make your trauma assessment a lot easier if you have this medical assessment down, because this one is the more involved. It has a lot more questions and details that you need to cover. If you can do this, then the trauma assessment will be super easy. So feel free to reach out if you have any questions, and we'll go over this again once you get into your skills session.